So first what we have here is a discussion of obsessive compulsive disorder, body morphic disorder, and hoarding disorder. Though they're completely different diagnoses, when we talk about potential causes in the mechanisms of the brain that seem to be involved, there's pretty incredible consistency between those three. So let's talk about what they are first, and we'll talk about what might cause them and what we do for treatment. So obsessive compulsive disorder, you guys have heard of OCD, yes? Tricky thing, pop psychology has poisoned us. Just because someone might like to be neat does not mean they have OCD. Our society really kind of plays around with that word way too much. Equally complicating, there is a personality disorder called obsessive compulsive personality disorder. It is different than obsessive compulsive disorder, which we're going to discuss right now. Criteria number 1, the presence of obsessions. The word obsession in our English language is used in a variety of different ways. In clinical psychology, an obsession is an unwanted, intrusive, unpleasant, and persistent thought, urge, or image. That's a little bit to unpack there. Intrusive, what's intrusive? Pops into your mind that are unwanted, that are very unpleasant. They are either thoughts or urges, like this need that you have to do something, or an image. Not a hallucination, but kind of a picture that you have in your mind of something. They're coming on some type of a regular basis. They're persistent. So this is a person who's having these oftentimes really awful thoughts or urges or images that are very, very disturbing. It's popping into their mind, they can't control them, and they're very, very distressed and upset by them. So a compulsion would be any type of repetitive behavior, mental act, or ritual that a person feels driven to perform. Obsessions and compulsions often feed off each other, result in feelings of anxiety. What we know about obsessions is when people have them, even when they try not to think about them, it doesn't work. If they try to neutralize them, it doesn't work. If they try to intellectualize and say, okay, well, the school's not going to blow up because they just got a new boiler, it's safe there. It doesn't work. So what happens is the person has this thought or this image that's really, really upsetting and disturbing, and it's causing them great anxiety. So what usually occurs is it happens by coincidence, that if they engage in a particular behavior, somehow it takes the anxiety and lessens it. It's taking my anxiety and decreasing it. So do you see where this cycle starts? Really disturbing images or thoughts or what have you, and I can't get them to stop on their own. I engage in some type of behavior, which we call the compulsion, and whatever behavior it is, it reduces that anxiety for at least a time. The likelihood of me engaging in that behavior, whatever that behavior was, is very, very high. So now do you see where those two tend to interact? Okay, so that's obsession, that's compulsion. The third criterion is it's time consuming. It is taking up at least an hour or more of my day, or it's causing soft impairment. Of course, as with any disorder, we have to rule out any kind of medical condition that might present this way. We have to rule out any other mental health condition that could present this way. Rule everything else out. We've ruled out a head injury, whatever it is, and we see this pattern of symptoms, then we call it obsessive compulsive disorder. When we talk about the compulsions don't necessarily have to have anything to do with the obsession. I should say the content of the compulsions don't necessarily have to do anything with the content of the obsessions. If someone is terrified and has these horrible feelings of germs just being surrounded and this fear that they're going to get sick and it's consuming their day and they can't get rid of those, and they feel relief by washing their hands, and now they're washing their hands 17 times a day, yeah, that could be OCD as well. The thing, oftentimes compulsion can happen out of coincidence, classical conditioning. They didn't realize that it happened. Sometimes it's purposeful, but oftentimes it just happened and that's automatic and not intentional. The DSM-5 gives a more recent prevalence of about 1.1 to 1.8. In terms of comorbidity, we know that obsessive compulsive disorder tends to co-occur with anxiety disorders. Interestingly enough, OCD used to be in the category of anxiety disorders. The DSM-5 is the first time that it was separated out. Why? Because the etiology is very different than disorder, agoraphobia, specific phobia, and generalized anxiety disorder. So we tend to see high substance use disorders in people with OCD. The root of the obsessions are the anxiety that it brings. Comorbidities with other anxiety disorders, with depression, and with substance. If we ask the right questions, our kappa value on this is actually pretty good. Sometimes the compulsions are what we call covert behaviors. A covert behavior is something you can't observe. So you wouldn't be able to notice it unless you asked me. Might I not tell you? Body dysmorphic disorder. It's been around in the DSM for some time. They have a preoccupation with a perceived flaw or defect in their appearance. It's their own perspective, and others don't even notice it. It's a misperception of their own physical appearance. Criteria number 2 is they engage in repetitive behaviors or mental acts, checking themselves in the mirror to make sure, measuring what they think is engaging in these behaviors that center around this perceived defect or flaw. Have to do with comparing oneself to others. Criteria number 3 interferes with social and occupational function, so self-impairment. Time they spend thinking about, addressing, trying to cover up, trying to fix this flaw is about 3 to 8 hours a day. That's not a diagnostic criterion. The flaw that they think they have and how they're responding to it, consuming a significant part of their day. And obviously that's going to interfere with social and occupational functioning. First and foremost, before we diagnose this, we need to make sure it's not better explained as anorexia nervosa or bulimia nervosa. Someone might be convinced in their mind that the shoulders are so small. And we could measure their shoulders and show that it's completely average, but bringing objective information to try to counteract this perceived defect, it doesn't help. And the treatment it takes time. Plastic surgeons are trained on how to identify body dysmorphic disorder. No matter what, the person is never satisfied, and their perceived defect in their mind remains. Again, lifetime prevalence right around 2%. It is higher in the cosmetic surgery population. In terms of comorbidity, body dysmorphic disorder tends to co-occur with depression and anxiety disorders. Now, if you look at OCD and body dysmorphic disorder, you're going to start to see a pattern emerge. Similar prevalence, similar comorbidities. So hoarding disorder is brand new to the DSM-5. The act of hoarding is not new, but classifying it as a disorder is new. Number 1, difficulty discarding or parting of possessions, regardless of value. We're having a hard time throwing things away or giving them away. Okay? We're talking about regular everyday items generally that you have no use for anymore. Criteria number 2, a perceived need to save these items and distress when they do discard them. Generally what happens, and this is required to get a diagnosis, is the collecting of all these items. There's so much in their living space is so filled with possessions that generally aren't needed and often have no value at all. It restricts their space. That can become a hazard. It's not a requirement. Where collecting all this stuff could be a hazard, especially if the stuff that person's collecting is garbage or animals. And number 5, the hoarding is not better explained by obsessive compulsive disorder. We need to make sure this isn't schizophrenia. So you got to rule out things that could look like hoarding disorder. What we do know about hoarding disorder is people who meet this criteria, they seem to have very little insight into their behavior. In terms of comorbidity, hoarding disorder tends to co-occur with depression and anxiety disorders. Research will say anywhere from 2 to 6%. When we look at other countries who have recognized hoarding as a disorder, they are closer to 1.5 to 2%. There has been a significant focus on brain anatomy. So when we look at OCD, what we find is an overactivity in a couple of different brain structures. One of them being the orbital frontal cortex. We also see an overactivity in the anterior cingulate cortex. We talked about this before. And we also see an overactivity in the caudate nucleus, which is part of the basal ganglia. There seems to be in common a thought that they don't get that often the rest of us do get. How do you know when you're done doing something? People with OCD don't get that sense, so they never necessarily know when they're done. So when cognitive psychologists study OCD, this is what they come up with. You get a sentience, that feeling of done. Okay, so they don't get that. So here's the thing. So a cognitive psychologist is going to study thoughts, and they come up with this. Of course, a biological psychologist wants to know where in the brain is this process. Does this make sense to you? And so we think the anterior cingulate. So it's just looking at different aspects. In terms of body dysmorphic disorder, let's talk about etiology. We see an overactivity in the orbital frontal cortex and the caudate nucleus. Not the same as OCD, but there's overlap there, would you agree? When cognitive psychologists study hoarding disorder, one of the things that they have learned about the person's thinking and their cognitive style is people with BDD, body dysmorphic disorder, they tend to focus on details far more than the big picture. Also, what they have found is that people with body dysmorphic disorder, they put their self-worth far more in appearance than anything else. Is it safe to say our society really focuses on appearance far more than it should? Most people aren't 100%, in love with their appearance. That's just called being human. So might appearance be a piece of that? Sure, but the point is, people with body dysmorphic disorder, they put most of their self-worth on appearance. And so this is what psychologists have to address in therapy. They have to help a person redefine self-worth and what defines it. And that's why it takes a long time. With hoarding disorder, when we look at the etiology of hoarding disorder, overactive would be the orbital frontal cortex and the anterior cingulate. When researchers look at the cognitive style of people who engage in this hoarding behavior, there's a couple of things that come up. One of the things is they find these folks have really poor organizational skills and pretty poor concentration. How we organize things has to do with the organization of our thoughts, the organization of our space, how they process things. It's not necessarily systematic, it's kind of coming everywhere. That has to do with your organizational style. So again, with hoarding disorder, we see a very poor organizational style. Problems with attention. We see indecisiveness. Should I throw this out? Should I not? Should I fill this? I can't really decide. Poorly organized. Their attention isn't sustained very well. So maybe they have good intentions to organize stuff, but they just can't, they don't have the wherewithal to follow through. And then you add in this indecisiveness, the task becomes overwhelming, and hoarding is the result. Right? When we look at those who are animal hoarders, they usually have attachment issues. So attachment is the root of a lot of things. In terms of treatment, we've got a couple of options. Antidepressants tend to work really well for all three of these. The SSRIs or the TCAs. Pretty good success. So it is noted in a lot of the research that some symptoms still persist. Last thing in terms of treatment, and this seems to be required, ERP, that is exposure and response prevention. Yeah, let's talk OCD for a second. What are we exposing the person to? Expose me to the thought that what if that actually happens? You're purposely exposing the person that terrifies them the most, that is causing the most anxiety. You prevent them from responding. So whatever their compulsion is, you don't let them do it. You kind of help them work through the worst case scenario. Then you go back to the possibility, probability. Is it possible that might happen? Yes. Probable. Success rate with exposure and response prevention can be upwards of 75%. That's great. But I'm here to tell you that some people won't ever even agree to this type of intervention.